We need midwives to be women's advocates, not just on the level of individual women, but at the level of systems and organizations and influencing how care is delivered.
When you come into this world, surely a midwife was there beyond the trimesters and postpartum. The love they show in the childbirth is extraordinary and leaves the positive prints on the mind of the pregnant and the newborn for the rest of the life. Here we will talk with the midwives from around the world and will explore the midwifery dimensions. Today we are going to talk with Shawn Walker, who is a midwife and researcher in the King's College London. Hi Shawn, welcome to the Midwifery Dimension show. We want to know more about you. Could you please tell us something about specialties you deal in midwifery?
Yes, so I am a midwife who specializes in physiological vaginal breech birth, and I am a clinical expert and a researcher in this area. So at the moment, I am a senior researcher at King's College London, and I am working on a National Institute for Health Research Advanced Fellowship, which includes doing research about the feasibility of a trial of the physiological breech birth methods that I've been researching for the last 10 years. If you'd like to know more about what a clinical breech specialist midwife does, a breech specialist midwife is like any specialist midwife in the National Health Service. We work in that particular area, so we have special knowledge of the care pathway for women within that area. So in my day-to-day clinical work, when I work clinically, what I might do is I might perform the presentation scans if a woman has been referred for a suspected breech presentation, and then I would confirm this. I would counsel her about her options given that her baby is presenting breech at term. So we would talk about the possibility of external cephalic version, which is turning the baby to head down using pressure on the abdomen, or we would talk about planning a vaginal breech birth or the option of planning a cesarean section. And if the woman doesn't have any additional risk factors, this counseling can be done entirely by a midwife. If the woman does have additional complications, it's really important that her obstetrician do counseling regarding those complications as well. So following counseling, I am a trained external cephalic version practitioner. So I would do the attempt to turn her baby to head down. Sometime I will be training other people, either trainee doctors or midwives who are learning to become external cephalic version specialists. And then if the turning works, I would see her again in a week to confirm that the baby had stayed head down. If it doesn't, we would talk about what her options were. So I also do teaching. So well, I guess the other important thing that I do is attend vaginal breech births, whether those are planned or unplanned. If my team or the woman calls me, then I would attend to help the staff on duty on the day as a safety net. So my role is not to manage all of the breech births that occur at my hospital. My role is essentially a teaching role. I attend to keep the birth as safe as possible and to teach others how to attend breech births in the safest possible way. And I also do the teaching either the birth or I will do the teaching for trainees and for update. In the hospitals where I work, all doctors and midwives receive annual mandatory update, which includes vaginal breech birth update. So I will do that training plus teaching at university level as well for the trainee doctors and midwives. I also will I and other breech specialist midwives will do audits related to breech practice. So we'll look at how many breech births there have been, how many of these were diagnosed or undiagnosed before labor, and what were the outcomes. So that's a kind of internal research or audit. I also do external research So this would be looking at things and using appropriate statistical tests to determine whether the findings that you have can be generalizable. So at the moment, I'm working with another specialist midwife named Emma Spillane, who is looking as part of her master's research project at the effect of timings and the intervals between the birth of the pelvis and the birth of the head, and that crucial time right around birth to determine whether delay at that point is associated with an adverse outcome.
You are a breech specialist. Why you choose to focus on breech presentation, whereas many other areas can be specialized in midwifery?
Absolutely. So part of the answer is that it chose me. When I first started to practice, I was practicing as an independent midwife, so outside of the national healthcare system. And because in the UK, National Health Service care is free for everyone, people generally go outside the NHS when they need to get care for something that the NHS isn't providing or not providing well enough to meet their needs. And so I found that women were coming to me as an independent midwife and asking me to facilitate their breech births, which is the opposite of what I wanted to be doing as an independent midwife. But it highlighted to me that this was an area of unmet need for women within the National Health Service. So rather than doing breech home births, which is one other way that this could have gone, and many other midwives who have led and maintained breech practice, that's what they have done, and that's how they've got their skills. But I felt the time had come to create a pathway within the National Health Service because I felt the safest way to facilitate breech births was working together with my obstetric and neonatal colleagues to make sure that the woman received all the care options that she may need if there were to be an unexpected complication. So early on in my career, I decided that this care pathway was important. And then I just gradually discovered that it wasn't very easy, that the problem wasn't going to be solved overnight and it wasn't going to be solved very easily. And I then decided that I was going to focus on this problem. How do we make vaginal breech birth safer and more available within the context of the national healthcare system? And I can't see that the many questions that need to be answered in that area is actually going to be drying up by the time that I'm ready to end my career, which is still quite a few years away. So I just kept working on this problem, and it just became one of those things that in order to do this thing well, I had to devote a lot of time and attention to it, which meant that I couldn't devote as much time to being what we call a generalist. A generalist would be a midwife who is really good at, for example, working on the labor ward and eventually goes on to become a labor ward coordinator or a manager. That type of midwife is very good at midwifery across the board in lots of different areas of midwifery. Instead, I'm more of an advanced specialist, so I've concentrated in one area. So some examples of other specialists that we have in the NHS are midwives who specialize, for example, in perinatal mental health. That's also an area where the information and the research that we have to guide practice is more than your average midwife will be able to absorb in her day-to-day working life or his day-to-day working life. So we need a kind of leader in that area who's going to help guide the practice in that area. And similarly, we have safeguarding midwives who help guide the care for women and their children who are at risk. We have things like diabetes specialist midwives. So on a diabetes team, you would have an obstetrician who's very used to caring for women with diabetes. You would have an endocrinologist who's very good at diabetes in general. And then you would have a midwife who is very good at the care pathway for women who have diabetes. So rather than focusing in on the question of the diabetes illness, the midwife will focus on how the woman who goes through the care pathway having diabetes receives her care. And for example, twin specialist midwives. And And these midwives are particularly good at making sure that those care pathways are as they should be, and that women are able to progress through them, get all of the medications that they might need, and all of the care that they might need, and the correct counseling and things like that. So I then chose to specialize in this area, and as far as I know, I was the first breech specialist midwife to have that title in the UK. There are now others who have it either as their main title or as part of their role. Many consultant midwives do this. But the reason that breech captured my interest so much, specifically vaginal breech birth, is that in order to do it well, you really need to understand the physiology. And this is another thing that midwives are particularly good at, understanding how physiological birth works. And what I find, and I'm continuing to find, is that the sensitivity and level of experience that midwives have with physiology needs to influence breech birth in order to make it safer. And once you have that combination, we certainly still need our obstetric colleagues, because there is always the chance with any birth, whether it be cephalic or breech, that the baby may need surgical intervention to have a safe birth. There may need to be an instrumental delivery. But in the majority of cases, and when it comes to instrumental delivery, certainly forceps are needed actually less often in breech births than they are with head first birth. So there is certainly a role for someone whose expertise is in physiological birth to influence this area of practice, and that's why it captured my interest so much.
Good to know that you are the first to get the breech expert title in the UK. How was the moment when you knew it?
Um, Well, it was a process really. So as I explained, I had been working independently, but I felt that the right way to do this was to work within an NHS setting, in a hospital setting, with my obstetric and neonatal colleagues. I occasionally worked within the hospital as well as an NHS midwife on the shift system, which was the only way to work within the NHS at the time. So I went and I said, look, I would like to pioneer this pathway. I think that it would be a good idea if we work together to work this out for women so that they didn't need to go outside of the system to have a breech birth. And so I made that pitch, and we worked together on the proposal and the business plan. And then eventually some funding was identified for me to do this 2 days a week. And we worked together to write my job description. So in a way, it wasn't a surprise because I helped to write the job description. But I was very proud when it actually did happen, and that was in 2012. Yeah. I guess I would just say that for midwives who want to improve things for women and birthing people, and if you see an area where you can influence practice, I would encourage you to be brave and follow your vision, because we need midwives to be women's advocates, not just on the level of individual women, but at the level of systems and organizations, and influencing how care is delivered.
In breech presentation, turning head down is one of the big challenging tasks and risk involved. What are the challenges you get in this process?
Okay, so oftentimes breech is considered abnormal. Okay, and then the question becomes, how can we make it more normal? So there's two ways to do this. One is to try to turn the baby head down so that the baby conforms to what is the normal for most babies, which is coming out head first. The other way to do this is to discover what is normal for breech. So not to compare breech to cephalic birth at all, but to find out, like we do within cephalic birth, we have births within all of the babies born head down that are normal and some that are not. We have that within breech as well. So there is a normal for breech that we can identify. And that's where a lot of my research centers on, finding out what that normal is so we know when we have to apply intervention or not in a vaginal breech birth. However, the other way to normalize, if you will, breech birth is to turn the baby head down. And this would be appropriate in a lot of different instances. The most obvious is if you don't have skill or support within your hospital to manage a vaginal breech birth, then the woman's best option for a vaginal birth is clearly to turn the baby to head down. And also, sometimes, especially in the UK, we have generally a pretty good home birth service. So if a woman is really wanting to give birth at home and she's rented a pool because she wants to have a water birth, what I say is, yeah, the best way to do that is to turn the baby head down, because it's much harder for us to get to her the experts that she may need at her breech birth. So turning the baby head down is one way to do that. And so, but the thing about external cephalic version, which is the turning the baby, the thing about turning the baby is it's only successful almost 50% of the time. And that is really dependent on whether you have someone who has a lot of skill in doing it. So an expert practitioner will have a success rate of 50% if they are performing baby turning on almost the entire eligible breech population. You can get higher success rates if you select, but then the ones that aren't selected don't have any chance at all to turn. So turning the baby head down is one possibility. Now, the evidence doesn't indicate that babies are at higher risk if you turn the baby. It also doesn't indicate that you improve outcomes if you turn the baby. So turning the baby is about increasing the woman's chance of a vaginal breech birth rather than improving the outcomes for the breech baby themselves. So none of the studies indicate that it will improve outcomes for the baby, but it will improve the chances of a woman having a vaginal breech birth. Most women find it very bearable. Unfortunately, it's hard to predict ahead of time who this is going to be. So some women respond by saying, "Is that it? The baby turned? I hardly even noticed what you were doing." Other women's, it will be very, very painful. So I just like to tell women that they are in control, and I will stop what I'm doing at any point if it becomes unbearable for them. It's not something they have to do. But it is, we will go through the counseling and make an attempt if that's what she would like.
Please share your memorable moment when you feel proud to be a midwife. Moreover to the breech expertise.
Yeah, I think that because I'm a researcher as well, so I obviously feel very proud every time that I have successfully um, helped someone to give birth and the birth has been safe. Um, but not every birth turns out that way. So one of the other things that has influenced me is very early on, I had a baby where the birth didn't go straightforwardly, and it was very difficult. And the thing that everyone fears with breech birth, head entrapment, occurred. And my doctor colleague and I worked well to release this, but it didn't go as smoothly as it could have done, and the baby had some damage from that birth. So that was another thing that spurred me on to want to do further research, because I thought, is it me? Did I have not very good skills, myself and my colleagues? Did we fail? Did we not do what we were supposed to do? Or is it that the training that is available was not good enough to help us to help this woman and baby in this instance? And I wanted to find the solution. I wanted to find the answer to that question really honestly. And if it was our fault, I wanted to take responsibility for that. But if there was some way that we could have done differently, I wanted to know what that was. And it wasn't immediately obvious, because at the time, the training wasn't very good about how you cope with head entrapment and what the causes of head entrapment were. And so I did my early research and listened to people describe how they solved that complication. And I realized that the training wasn't there about how to deal with the head when it becomes extended at the inlet. And that is one of the things that's now covered on the app that I've shared with you from Touch Surgery in the breech birth simulation. Um, and I find it very moving because now I regularly get messages from people who have encountered that complication and have known how to resolve it, and in many cases have probably saved a baby's life and have certainly been grateful for the skills. So I think that's when I feel the most pride that I didn't run away from what was a painful situation that no one would want to repeat. And that's why many people want to avoid breech birth. Understandably, it was the worst experience of my midwifery career. I, but because of that experience, while I would never wish it on that family for them to have had that happen to them, I don't regret that it happened to me because it alerted me to a need and it helped me to find solutions that have prevented the same thing happening to other mothers and babies, many mothers and babies. And I am really proud of having contributed to better outcomes for breech births in that way.
Obstetrics love C section if the pregnancy is complex. Do you react when you hear about C section in the case of breech presentation?
Okay, well, I think that the place that I start from is acknowledging that nobody gets into gynecology and obstetrics or midwifery without wanting to help mothers and babies. So if someone is recommending a C-section, it's because they genuinely believe that that is going to be the safest way that they can deliver the baby. And understandably, people who perform C-sections regularly, they will feel very comfortable and they will know I will be able to it's very likely that I will be able to hand this woman a baby that is in perfect condition if I do a C-section. However, midwives a little bit more often probably we hear women's birth stories because they fall pregnant and they come to see their midwife. Certainly this is how it works in the UK, and they tell us about their previous experience and why they want the same or something different. And I think we hear the effect quite a lot of women who feel that they didn't have a choice, that the C-section was the only option for them. And sometimes we end up supporting women in the next pregnancy who then go on to have an adverse outcome that may have been related to their cesarean section. So it's very reasonable both that doctors feel that C-section is the safest thing that they can provide for this woman, but also reasonable that women want more options, especially women who know that they may go on to have more children in the future. They want to make the informed decision themselves about which option is best for them. So I think that, and also it's important to acknowledge that women will sometimes need a cesarean section. There are times that when that is the safest and the most appropriate thing to do, and the woman has chosen that because we've said, look, this is now what the situation is and it's looking a bit safer to do it that way, and she will say, yes, please, that's what I need. And I thank I thank God that we do have the option of providing cesarean sections for women who have obstructed labors and or their babies are at risk. So I don't want to set up a situation that kind of pits midwives and doctors against each other, because I find that it's safest when we all work together. And I completely understand why my obstetric colleagues might feel more comfortable recommending a cesarean section. But I have plenty of obstetric colleagues now who are very, very comfortable with vaginal breech birth and we've taught each other many, many things because it's a constant learning experience.
What are the challenges you find when a planned vaginal breech birth is becoming a C section? How you deal with it?
Okay, so um, Sometimes this happens before labor. So the most common reasons why women who have planned a vaginal breech birth with me have ended up having a cesarean section are either that their waters broke and their waters released and they did not go into labor. And at the moment, we're not doing inductions because we're still getting used to doing vaginal breech births, and um, adding syntocinon and other induction elements into the mix makes it a little bit more complicated. So if somebody's waters release and she does not start contracting, then she might have a cesarean section. Similarly, sometimes a woman plans a vaginal breech birth at 36 weeks, and suddenly she's 41 weeks, maybe near to 42 weeks, and she still finds herself pregnant, and again is either not going into labor or her baby has now become really quite big and she prefers to have a cesarean section. Um, Again, with big babies, the risk is mostly to mothers rather than to the babies themselves, because bigger babies are very resilient in labor. But to mothers, the chances of having a cesarean section in labor go up with a larger size of baby. So some women choose to have a pre-labor cesarean section instead of a much higher chance of an in-labor cesarean section because the risks to mother are greater when she is in labor. So in labor, sometimes people have cesarean sections. What I find, especially with first-time mothers who have frank breech babies, the ones with extended legs, extended breech, they can plateau around 6 centimeters or around 9 centimeters just because the baby actually has to turn a bit and kind of wiggle the hips through the pelvis. But if the legs are really splinted, especially if it's the woman's first baby, sometimes the legs can be really splinted and it can be really hard for the baby to turn around that curve. So sometimes there's a plateau and we just make a calm decision that it's time to go to cesarean section. Sometimes when the second stage is very, very long, that can introduce a little bit more risk to the baby as well, and we need to have a cesarean section. And of course, the other time is when there is a significant problem with the fetal heart rate because of cord occlusion, and that is an emergency cesarean section rather than a kind of calm decision about the labor stopping or not progressing as quickly as we feel it's safe to do so. But I would say the incidence of having a crash emergency cesarean section is similar between breech and cephalic birth. So even though there's a higher cesarean section rate with breech birth, it's not all urgent emergency cesarean sections. I should say that all of the breech births that I've attended have occurred in hospital except for one. And I was actually supporting a home birth obstetrician at that birth. So my experience has been in hospital, and so the issues of transfer haven't come up. What I would say is that if you are supporting breech births out of hospital, your threshold for making that decision is lower, obviously, because if you think that there's any chance that this labor might be progressing slowly, or if the heart rate is in any way irregularly, you need to start thinking about transfer and getting the woman to a situation where the cesarean section can be performed quickly if needed, and ideally be there from the start. That's what I advise. But all of my head down babies that I have had personally have been born at home. So I completely understand that some women will make that decision anyway. And I understand the appeal of that. But ideally, we want to create a safe, cocoon-like environment within the hospital where the woman feels that she can give birth in the way that she wants to, in the place where it is best. But what my kind of clinical speciality is not so much about making sure that the woman gets a C-section if she needs to, but managing any sort of stuck bits with my hands and supporting other people to do that, just like one would manage a shoulder dystocia. So midwives have skills when the baby is coming head first, that if the shoulder gets stuck, we know how to help the baby to come out, even though the shoulder gets stuck. With breech, the skills that you need at the last minute are very similar to those needed to manage a shoulder dystocia. And then the skills from experience and research that I have help people to recognize when it's time, either because of the amount of time that has passed since the pelvis has been born, or because of the position of the baby, has it rotated or not in the way that it usually does, according to what we know is normal for breech, and then using one's hands to help either the arms to come down in a safe way or to help the head, like you see in the touch surgery app, how you do those maneuvers and how you know that it's time to do those maneuvers.
As we know, you are a researcher as well. In what areas you do the research?
Okay, well, I'll describe one recent, I'll describe some past research and I'll describe what I'm working on now, because most of my research does have to do with breech, but I look at it from different angles. So when I started researching breech, I wanted to know what skills someone needed to become a breech competent practitioner. So I talked to experts about what they felt, and I used consensus methods to come up with a list of competencies that practitioners should have. And I also talked to people who were developing competence to see how that happens. So, how does one become a competent breech practitioner? How do they even get experience in 2010 when I was doing this research? How do they even get to enough breech births to get experience? So I talked to people and used qualitative methods to analyze those interviews. And those were the interviews in which I also discovered that other people had encountered this extended head complication and also did not have that their previous training, despite being highly trained as well, did not include ways to resolve the extended head complication. So, and then we moved on to trying to come up with ways of describing when help was needed. So with my colleague, Dr. Anke Reiter, who is an obstetric breech specialist in Frankfurt, Germany, we looked at videos from 42 breech births that went very well. And we looked at, we were very nerdy about looking at the timings. We went through all the videos and said, okay, the bottom where the buttocks were born at this point, the pelvis was born at this point, the umbilicus was born at this point, this arm here, and then the head. And we calculated very precisely what those time intervals were because we wanted to be able to describe what is normal for breech. So what is the average time? And it turns out that the in births that have gone well, in this sample of births that have gone well, that 75% of the breech births were finished within 3 minutes of the pelvis being born, which is a much shorter interval than we were previously taught to expect. And so that helped us to define normal for breech, but we only looked at births which there was a good outcome, right? So now my colleague Emma Spillane, who's a consultant midwife who also specializes in breech birth, and I are looking at intervals. We're doing a case control study. So a case control study is where you take an adverse outcome. So we use the definition of an admission to neonatal unit. So among the babies that were admitted to the neonatal unit, and then you look at 2 cases. So we looked at 2 others that weren't. So they had a good outcome as opposed to an admission to the neonatal unit. And we compared, do they take longer, or what is it that is different about these 2 samples, the ones that have not been admitted and the ones that have. And taking longer is definitely ending up to be a really significant risk factor for neonatal admission. And interestingly, it doesn't look like a longer labor, like first stage or even the pushing stage of labor, seems to be predictive of a bad outcome. That doesn't seem to matter. It's really that crucial few moments around the time of birth. And that's why it's so important to get someone there who has had really robust training and experience. And that's why you're going to improve the outcomes by making sure that someone is present at the birth who has had really good training about doing those maneuvers and knowing when they need to be done. So those are the kind of things that we research.
Thank you very much, Shawn, for giving your time for the show and sharing the thoughts and your expertise.